have time, I quickly go through the other set of slides regarding the study of the European Parliament, which is online and available, so you can always download it and have a read at that. It's 70 pages long, but it has maybe 10 pages that are worth your attention, where I look at the legal structure regarding the new proposals for the European Health Union, the one that were submitted by the European Commission in November last year, actually November 2020. In the 11th of November, there was 3 pieces of new legislation that were submitted by the European Commission to the European Parliament and the Council for discussion. And they are labeled the European Health Union Pack. But when you look at them in particular, you see the ambition for what the European Commission calls the European Health Union is very low. And this is my first statement, is that although politically this is a quote from a speech from the President of the European Commission in September 2020, when she says it is very clear we need to build a stronger European Health Union. So this sentence, if we were to dissect it, it means that first, there is already a European Health Union, which is a very debatable subject. We could stay here one day, do we agree with this? There is a monetary union, that's for sure. We have a central bank, we have a current common currency, but mind you, the current currency has 20 years only, but we started 60 years ago. We started thinking about a common coin, the euro. It was not even called the euro, but we started thinking about common monetary tools in the 60s. We started working on that in the 70s. And in the 80s, we started experimenting with the echo and parity of coins and so on. So in order to get to the Eurozone, and not all countries are in the Eurozone. That's why I say even the monetary union is not a European Union in the sense that all countries are there. So it is perhaps a little bit provocative when Mrs. van der Leyen says, we need to build a stronger European Union. Well, we don't have a European Union, many people would say. And how can we build a stronger one if we don't even have one? So that's a sort of the first thing for reflection and for your thoughts. Now, let's look at why we don't have it very quickly. And I know you've covered some of these materials, so I'll just be very quick. For me, not just because it was signed in Lisbon, but because they are the last treaties, the Lisbon treaties, as they are called, they are, of course, the basis of the current union. The Treaty on the European Union, the Treaty on the Functioning of the European Union. These are the 2 pillars of the European Union. I always like to call the attention to the Charter of Fundamental Rights. And the reason I call this attention is because what is incredible for many, many people studying European Union law is how fundamental rights only became at the same level in terms of legal text, legal authority, at the same level in 2010. So this was 12 years ago. This is not that long ago that we put into the treaty a very important article that means that the Charter as a whole is part of the treaty. I will show you the article if you're not, if you never paid any attention to that. Then there's a very important article, which is Article 5 of the European Union, which has to do with subsidiarity. And the problem with subsidiarity is that subsidiarity means that whatever can be better solved at the local, regional, or national level should be solved at those levels and not at European level. But the question is always, what is better? What is better solved at the national level? and I will challenge this argument in that paper, in that study in European Parliament, to say that regarding healthcare and regarding health data, which is going to be the core of my talk to you today, I think we can't think about national, because health data is an asset that moves around Europe. And for some types of health data, like rare disease data or epidemiological data, we need cross-national comparison to take meaning out of the data. Otherwise, we cannot understand the data. And that means that the level, using the subsidiarity principle, the only level to which we can actually address some health data topics and some health data issues is always European, if not global, actually, for some areas. But anyway, I've talked to you about the cross-border directive, and as I said, the Charter of Fundamental Rights is important. Why? Because the Charter has different elements of health. And I always tell this to some of my students, is that, please go and check internally the Charter of Fundamental Rights. And if you do that, you see that we have a right for children, Article 24 of the Charter, the right to such protection and care as is necessary for their well-being. Now, if a children needs this care and protection, and look at, for example, rare disease in pediatric cancer, then you need to build European data sets. The rights of the elderly. The Union recognizes and respects the right of the elderly to lead a life of dignity and independence. Now, if a citizen, an elderly citizen, cannot move from his city council because he has telemonitoring equipment in his house, but if he moves from his house in Sardinia to his house in Portugal, the telemonitoring system is not compatible, then he's not free, right? He's not truly independent. So one could evoke Article 25 of the Charter to say that there is a right to independence in the elderly that, in order to be well insured, requires a European Health Union. So I will use these articles later on. And why can we use them? Because of what I said to you, the famous Article 6 of the Treaty of the European Union, that says that the Union recognizes rights, freedoms, and principles set out by the Charter of Fundamental Rights as adopted in 2007, which shall have the same legal value as the treaties. So this little Article 6 of the European Union Treaty, combined with the articles inside the Charter, means that these articles, these rights, are equal to the rights that have been outlined by the treaties of the European Union. And therefore, when we look at the general article for healthcare, the Charter has an article for healthcare, which is saying, under the conditions established by national law and practices, high level of human health protection shall be ensured in the definition and implementation of all union policies and activities. Now, the problem with this article is that it was well designed. It has the subsidiarity principle in it because, you see, established by national laws and practices. So while the European Union is saying everyone has a right to health, it is still, unfortunately, in my opinion, but I am biased, I'm very European friendly, okay, some people are not, but I would say, unfortunately, because it states under the conditions established by national laws. So in a way, we have a provision that says, yes, European Union shall take into account in its policies and activities the rights of health, but it shall do so under the conditions established by national laws and practices, which creates a tremendous heterogeneity, right? This, I don't think I need to explain this to Italians today. 2 years ago, we know how different it was, when the pandemic started in Italy, in Portugal, in Germany, elsewhere, right? How different our systems were, but the problem is they are exactly the same. 2 years later, they are exactly the same. In my personal opinion, we have not changed, but we didn't change any law. We didn't change any European law. We changed slightly some operational rules, but we didn't go to the treaties. We didn't change any fundamentals of our European law. Now, we can look at it on another perspective, which means, well, if this is true, health protection, then this means that preventive and curative healthcare is national, okay, but health protection or promotion, which is here, shall be ensured in the definition and implementation of actions. So one could think about this the other way around. Well, while countries have sovereignty and subsidiarity over healthcare, when we talk about health promotion and health protection, that could be a function for the European Union. So, and then we need to combine this with the free movement, okay? Now, when we mix free movement with health, we get the problem of cross-border health, right? We already had this pre-COVID. With COVID, we have it even more obvious, right? So when we combine the right to free movement, and which is undisputable, right? It's a fundamental right in the European Union legal ecosystem, let's call it this way. Now, if people move around, and then you combine with Article 168 of the Treaty of the Functioning of the European Union, which says high level of human protection is to be ensured in the definition and implementation of all union policies and activities, then, okay, when the people move, you need to ensure that that doesn't collide with high level of human protection. And how did we solve this? Well, I'm going to jump these ones just very quickly. We solved this with a directive, well, partially, I would say, the Directive 2011, which comes out not because the legislator wanted to do it. It was a demand from the European Court. So when the cases went all the way to the Court of Justice of the European Union, Union Court of Justice said, actually, the citizens are right. They can buy and they can get services from other countries and still get reimbursement from their home country, at least to the value that their home country would have expended on them. And this is the pillar of this directive. So to try to solve the problem of cross-border rights, we have at least this first legal piece. We've already talked about the subsidiarity principle. And if you analyze the Article 168 of the Treaty of the Functioning of the European Union, you would see that there's a lot of descriptions, and then there are some areas for European Union activity, which are normally taken care by DG Santé directly from the Commission, safety of organs, substance, blood and blood derivatives, problems with veterinary and phytosanitary fields, and then things that I know you've covered in your course already extensively that have to do with standards and high quality of medicine products and medical devices. So this is the basis for EMA creation, the European Medicines Agency. This is the basis for this is the legal basis for the new medical device regulation, which I'm not going to cover. Then there's an whole lot of topics related to cross-border health risks, which have to do with the best example now is COVID, right? So it's a pandemic. This was the basis for the creation of the European Center of Disease Control, and it's only in this area and a little bit on vaccines that the new legal pieces branded European Health Union were proposed in the 11th of November 2020. Now, what I want to convey to you today is then that, okay, these are the buildings we have, the building blocks we have, but perhaps if we are really serious about the concept of a European Health Union, we need to start by conceptualizing it. We need to start thinking what could be a European Health Union based on the current treaties. So European Health Union is not a national health service like the UK has. It cannot be, because that doesn't even exist in some countries. It cannot be the Italian model, because that suits Italy. So it has to be something different that could suit a little bit everyone, and still, and that's the question, what could it do? What additional value could this European Health Union do? So let's think. In my perspective, we need a concept, and I'm going to suggest to you to think about this in 3 pillars: data, patients, and professionals. And if we had more time, we could dissect what I mean by digital patients, digital professionals, and data. I think you know what it is. But the concept of fair data, which has to do with findable, accessible, interoperable, and reusable health data. But let's go one step back and say, okay, what about the concept? So for me, and I've written a small article on, and you'll have the slides, so you can click here and go to this article on health data systems, on health digital healthcare systems. It talks a little bit about the work we've done here in Portugal, but then outlines a vision for what are digital health systems. And in my opinion, digital health systems are preventive, paperless, empowering, and basically they are focusing on prevention and ensuring everyone can be their own healthcare promotion and healthcare creator. Why is this important? Because this means that telehealth, AI tools, and all sorts of digital technology can be used to allow citizens to protect themselves from disease. And in this case, then, what could be the 3 pillars for a new EU-wide health system? As I mentioned to you, these would be 3 pillars: data, patients, and professionals. And let's see what we already have. And it's important to build on top of what we already have and not from new. We already have a personal data ownership. So we have solved. So when you intersect data and people, you have the problem of personal data ownership. This has been solved. The GDPR is clear as water. Data is of the citizen, data is of the patient. There are rules to use data, there's rules to process data, and that's fine. Well, it's not fine, it's very complicated, but anyway. Then we have European level medicine and research. Paradoxically, while the health system is national and the subsidiarity principle is very strong in the healthcare domain, when you look at research, even the treaties, European treaty talks about European level research and European level research agenda. And I think you all know that many researchers in Italy, in Portugal, everywhere, they live on EU funds for research. So there is a very active research agenda for Europe. And then freedom of movement on professionals and patients means that both professionals move, which has the problem and the difficulty of professional recognition, mutual recognition, but also means cross-border care, which we've talked about. It means we need legal basis for telehealth. We have no solid legal basis for European telehealth. So if a doctor in Pisa now decides to start offering telemedicine services to patients in Portugal, and let's suppose he's working on, for example, dermatology, and he has a problem, he does something wrong, What is the malpractice rule that applies? Is it the Portuguese rule? Is it the Italian rule? What are the rules that apply for telehealth services across Europe? It's not clear, it's not finished. And then digital. Now, national level systems are very heterogeneity. So different countries have different systems. Digital health is the common EU space. And new concepts are needed upon which to build this super level health system. So what I'm trying to suggest to you to think today is that, well, perhaps the European Health Union is a European digital health union. We're not going to put every patient to go to a hospital somewhere in Brussels, right? The European system is not that you would have doctors that are coming on a helicopter from other countries, right? So that could happen in a crisis, but that's not the system that I'm talking about. I'm talking about a health data system. So as ideas to make you think, we may focus on these three dimensions: health data, digital patients, digital professionals. And these would be the things, the tools we need to create a high-level digital health system union task force, perhaps to raise political impetus and orchestrate different parts of the Commission and different parts of the European Union, link up different initiatives, legal initiatives right now, from AI initiatives, European data space initiatives, and health service reform initiatives. Regarding digital patients, we have the problem of empower and protect. So we can look at a European strategy for telehealth, telework, and telelife, for example, as a communication. So this would be soft law, pushing the bar and saying, why don't Europeans telelive? It doesn't mean you live always in your house, but it means that there could be new rules for teleworking and new rules for telehealth at the European level, and also establish a European telehealth facility. So this could be this is not a digital hospital, a virtual hospital, but a mix of competence center and a stimulating and harmonizing hub. So an organ, I'm not talking about an agency, that could perhaps diffuse and distribute and encourage people to think about telehealth. Regarding professionals, I think we need a sort of a digital health driving license. So we need to think on how can we prepare professionals, some like yourselves, to actually use digital tools correctly, be cyber safe and use IT, but also, and this is perhaps a little bit more provocative, create a registry of professionals. So having a European registry where we know that this person is a doctor, not at a national level or a regional level, which I think is the case in Italy, that you have a registry, the doctor is registered in the region or in the national level. I don't know, you will tell me in the discussion, but that's not the point. The point is we do not have a European registry of doctors or midwives or nurses, which stops people from traveling and offering services elsewhere, because it makes it very difficult. You have to double check every time a doctor wants to work in another country, in another member state, he has to present his paperwork. There is mutual recognition, but you still need to file all the paperwork, which for telehealth doesn't make any sense, because your service is going to be offered online across Europe, actually across the world. So how could this be done? And what is the rationale on the treaties? So this slide is very, very busy, but it's the same ideas. And what I'm putting you here is what is the rationale on the treaties and the Charter for Fundamental Rights. Regarding health data, the rationale is a European health data space or cross-sector legislation should integrate the needs of health, but health sector has specific challenges for data gathering and using. So these specific challenges means that at national level, it makes sense to do certain things, while at EU level, secondary use is only meaningful to certain European Commission bodies if there is a coherent approach in fostering and strongly empowering high-level task force. So what I'm saying is that we can twist the articles in the treaties to say actually that in order to have a good European health data space, we need both local usage of IT systems as well as European level usage. Regarding digital patients, foster remote care of elderly and chronic patients and has to do with the protection of health. And perhaps some of these products, telehealth products, need to follow the single market philosophy, have a CE seal, and for example, maybe EMA needs to start looking at mHealth solutions. Of course, you've already discussed about the medical device directive, the medical device regulation. So you know that this is coming. The software as a medical device is something that is now on the table, is not under the table, is on the table. So we can look at IT systems as a medical device. And if we do so, then we should look at EMA and think, is that agency prepared to regulate, control, verify software? Does it need new capacities, new competencies? And how can that be done? And then finally, digital professionals, which may mean that free mobility of health professionals only really creates competitive advantage to the European Union and promote health protection if there is joint training, capacity to use digital tools, remote working under legal and liability stable environments. So there's no point having professionals moving around if all the liability regimes, medical liability regimes are different. So there is some harmonization of medical liability regimes that may be needed. So I think I'm going to stop here now for a while, also to see people's faces. And then if we have time, we'll go into, very quickly tell you about the study that I presented at the European Parliament, which is somehow a narrower version, looking more at the data aspect. Over to you. Questions, comments? Maybe I was very fast, but feel free to comment. There's no right and wrong answers.
A very quick comment from my side. Do I understand you correctly if I say that your vision is about a European infrastructure for connecting and intersecting the different regional, state, and EU level competences?
Yes, I think the word, if the word infrastructure means processes and data, yes. If the word infrastructure would only mean a sort of an IT infrastructure.
No. I was thinking of legal infrastructure.
Yeah.
First of all.
Yes, I think European Health Union, if you look at the proposals, and I dissected them very carefully in that study for the European Parliament, the proposals that were put forward by the Commission in the 11th of November 2020, if you read them carefully, they are very timid. They are just a slight improvement of European Centre of Disease Control power. They create a slight addition to the competencies of EMA regarding vaccination production and vaccination oversight because of the current crisis, and then they upgrade the so-called cross-border threat regulation mechanism. So what happens? What are the powers that can be set in place if there is a pandemic, if there is a European-wide crisis, like we had with mad cow disease, we had with flu, a flu, and then now with corona. But this basically leaves untouched most of everyday topics in health.
Yeah, I'm afraid that I mean I very much sympathize with your vision. On the other hand, I'm thinking of the precedent of the digital market, which started as a grand project with a very relatively small
result. Yeah.
Result.
Well, I think the digital single market strategy again. Perhaps it will take longer. I think the problem is time. For example, when we look at health IT companies, they struggle a lot to sell in different countries because the languages are different. The way data is structured in the countries is very, very different. But also because the processes are so different. The way care is organized in Italy is so different from the way it's organized in Spain. Then for an IT company, it's hard to have a product that could fit the different models, right, of healthcare. But I think this is, as people say, it's a cycle, right? If you never have the legal basis for digital single market, we would never be talking about single e-health market or digital health market. And if we don't talk about a single market for digital health, in a way, we say, okay, different countries, different processes, different IT. And we never move out of this this problem. And
this fragmentation,
Yeah, and I think the fragmentation means that we have, and maybe this is not so obvious in Italy, but when you talk with countries like Croatia or Slovenia that have 2 million people, with 2 million people, you have no size to get, it doesn't scale up. You cannot create, for example, a efficient national telemonitoring center because the scale is too small. So the operational cost is always going to be very high. And this is
a threshold which is difficult. Yeah, sure. I see the point.
Michaela, what do you think about all of this? Michaela, are you there?
Yes, I'm here.
Michaela, what do you think about this? Do you think that we will ever have a health union, or it's just a figure of speech, literally, because it was used in a speech in September? It was used in a communication by the European Commission in November, and then it was never used after. That's important to mention.
I think it's quite hard to develop it because the countries in the European Union are so different and the standards are different in every country.
But do you think data can be a common ground for starting to build something common, or it's not useful at all?
Yes, it will help, I think.
Okay. Luisa, what do you think about all of this?
Well, I don't know. I think that it could be really, really valuable, but it means that many things should be changed. It means the technological infrastructure and also the law part and also the many interests that for instance, doctor may have in the different countries. So it's very challenging. It's a great challenge. I think we should do, but however, there are many things and many aspects which sometimes may be in contrast, which require a very long process. I hope not so long as it has been for the monetary union. So, but I think it's hard, because if even COVID didn't work to make a step forward, what do we need to move? So if this doesn't work, it's only political matters, and it means time. I don't know.
Okay, yeah, I can take that argument forward. Any other comments?
Not as far as Carmelo.
Actually, not a comment, but an observation, a comment in the sense that resources in Europe are not equally distributed, as well as the population. So this is a matter of fact, and we need to recognize that, for example, if we are speaking about notified body who are responsible for, let's say, approval, they are not equally distributed, so it's not easy to interact with them. And I don't know if digital infrastructure can help in accelerating this process. And I don't know if you have any news from EUDAMED, so this, let's say, database for medical devices that can accelerate the monitoring of the medical devices in Europe.
Actually, I don't, but I think it's a very important tool. To be honest, I think that when you build up a database of items, of devices, it kind of helps regulatory action, but also helps industry, because suddenly you have visibility over the competitors, which is always important, but also you know the dimension and the heterogeneity of the market, so you can devise a strategy for your own products. For example, here in Portugal, many years ago, when we had a troika intervention, we were forced to identify all medical devices by number. So we created, like we have for medicines, we created a national index for all the medical devices, all the companies. And this means that then, a few years later, we were ready to do central procurement of medical devices at a national scale, because we had those catalogs. We could launch the procedures using those numbers. So that standardization of the devices in terms of numbers, nomenclature, was instrumental to get the market in a different format and much more transparent. And for example, when then we went down to the road of electronic prescription of home care, we started prescribing home care on the software, but you can choose the device that is being given to the patient in the home based on this list, but it links to the price that the government is going to pay to the company and so on. So all of these ecosystem tools that allow Europe, in this case, they would allow a European ecosystem, they are fundamental because they are important for you to put the product on the market. But I always say, for many years, I was the leading of our digital health agency, but also our central procurement agency in Portugal. And if you don't have a number, a code for an item, you can't buy it, right, online. And so all these concepts of central procurement, digital procurement, e-procurement, at a European scale, they become possible because of this indexing. But also when you want to compare prices, which is a very, as you all know, is a very complicated story in Europe, to compare the prices for drugs, because the prices range very, very much. The same drug, the same device, sometimes has three times bigger price in another country. But if you know exactly what is the number, what are you comparing with, then you can easily say, this thing is the same as this thing, and in this country, this is 3 times more expensive. So someone is not doing a good deal here, and so it brings. If you're sitting as a regulator or public official, this is good news. If you're sitting as a company and you're incumbent company, very rich company, this is bad news. But if you're a junior company launching your products on the market, maybe this is a good news. I don't know if I was clear.
No, I'm super clear also, and I agree with you, of course, that having something easy to reach, if you have a marketplace, especially for, let's say, national procurement, everything is much easier, and actually where you can find the correct and the right cost. No, I was wondering when it will be ready.
No, I don't know.
Because
honestly, I don't know.
There are many, let's say, companies in which we have been involved in some projects that, let's say, are creating their own software to be compliant with this EUDAMED, but no one knows actually how it will be. So at least at the industry level. So for me, it was an opportunity to ask this question. But anyway.
Yeah. Thank you. So I will now just share with you any other question, comment.
But do you think that all the things that you put forward in what Valentina called the infrastructure, you would like to put them on place altogether, or do you think that you could do something more divided, so schedule this in different times? So making something like a project management. So the first step, doing, for instance, the possibility for doctors to make some telemedicine with patients from other countries, and then other things. Or do you think that you should do all together? I don't mean at the regulatory level, but at the real level. So making it happen.
Yeah, I think you are right. I think you need to take it as a progressive approach, and the question is, where do you start? Actually, it's an interesting discussion. I would say that the field, the real world, is not ready for it to happen at the same time, for sure. For example, in telehealth, the heterogeneity is complete. I mean, there are countries that do this as a standard day-to-day operation. I'm talking about pre-COVID, and other countries in pre-COVID times had laws completely forbidding telemedicine in the same union. Okay, this was 2 years ago. Now, after COVID, this has improved. There's much more homogeneity in the sense of legal tolerance or legal capacity for telehealth. But the experience, of course, is still very different, and the number of projects, the real world experience is very different. I can share with you that, for example, in Portugal, we have a national strategy for telehealth since 2019. 2019, yes. That is a national level, approved by the government. We have an organization that is caring for these things, blah, blah, blah. Guidelines, procurement instruments for buying telemedicine services and so on. Whereas I'm helping a country that is now designing their strategic outlook for telehealth. And they have almost no legal grounds for telehealth. So this is very heterogeneous. So, and also, if you look at Italy and Spain, some regional capacities have never been put at a national level, let alone the European level. So perhaps the model that I just described is even interesting for Italy, is to say, okay, maybe it's the Italian health union that could be modeled after some of these ideas. I know right now in Italy, you have a discussion on the National Electronic Health Record system 2.0, so the sort of the second generation, to try to connect the regional systems to a national level, right? To explore data at the national level in that specific country. So one could look at this and say, well, actually, in some countries, you still need to finish building the national level digital union to then participate in the European one. Why am I starting with this example? Because one of the legal pieces which is right now in preparation and should be out of the Commission to the Parliament and to the Council for voting is called European Health Data Space. And this is a legal piece to try to harmonize some aspects of secondary use of data and primary use of data. And in this case, it's coming from a central European level proposal. And it still has a lot of challenges. To answer you, it still will be faced with a lot of challenges at the national level in many countries.
Yeah.
So I've placed in the chat the study that I have referred to. And if you still have 5 minutes, I can quickly go through some of those slides. Is that of interest to you, or do you want me to go away and have lunch?
No, please start, because anyhow we can start later on in the afternoon. So even it's very interesting, I think.
Okay.
Carmen. Yeah, and we start later on. So students have, however, 1 hour and a half.
Yes, we can postpone the starting of the afternoon session. Don't worry.
Okay, so then let me just steal you 5 more minutes, and then I'm gone, because it makes it easier for your reading if you want to read the document. So basically, this challenge was an invitation. This is the slides that I've used online, of course, when presenting to the European Parliament last year in March. This study was asked from me in September 2020. In the heat of the pandemic, and the questions were, how did Europe use health data for controlling and managing the pandemic, and whether a European Health Data Center and a common data strategy would make sense for Europe. So I was very privileged to have to do this study. It was a long, hard work. It's all described in the document, so I'm not going to bother you with that. But basically, in terms of public health identification opportunity, member states share a set of health systems, common values. This exists. It has been actually reiterated by the European Council conclusions in 2006, so-called health system common values. I would say this is the closest you get to a common perspective on healthcare systems. You would need to go back to the European Council conclusions of 2006. But the EU response to COVID-19 pandemic since the first day can be characterized by heterogeneity. Despite its social impacts in the European Union. Regarding data, its availability and comparability, COVID-19 pandemic evidence that the EU has no clear health data architecture, and that even simple statistics on elements like intensive care beds, number of active cases under surveillance, or availability of professionals were limited by differing interpretations. So this is another point out of the report. In 11 of November 2020, the European Commission presents a pack of legislative proposals under the European Health Union umbrella to help address the EU response to public health crisis only, in my opinion, as I mentioned to you before. This report may be useful, this one, to MEPs in that context. So when I wrote this report, I was thinking about MEPs, members of the European Parliament that have to vote on the proposals of the legislative pack under the European Health Union. So my intention is to influence that policy making and that legislative cycle. There is no comprehensive public health data governance at the EU level, and very few member states could be said to have one at the national level as well. So for you to understand, I did interviews to countries, digital health agencies, public health directors, ministries of health, including Italy, people from the European Commission, people from the European Center of Disease Control, people from the US Center of Disease Control. Basically, the idea is to challenge whether it makes sense to create an agency or not under this European Health Data Space legislation, which is already under discussion. If you Google European Health Data Space legislation proposal, you will find that it is available on the website of the European Commission. But as you know, there are all sorts of agencies, European Centre of Disease Control, EMA, Joint Research Council, DG Santé, that has the responsibility for policy, health information, and digital services. Then I talked about health data levels. There's 4 types of data that may be relevant for European discussion: communicable disease, health systems, how many beds, how many hospitals, data on non-communicable diseases, diabetes, mental health. These are examples of important epidemiologically relevant diseases, right? I mean, there's more people dying of diabetes than dying of COVID, right? That's very clear. Let's be clear. And then what I call data with public health relevance, which is, for example, mobility data in a city, people's mobility patterns on their mobile phone, on their cars. When we look at those mobilities, we can understand if people were, for example, following confinement rules or not. This was actually a study done in Milano in 2020. And then a data governance architecture means to have an enterprise architecture, which means to define structures, leadership and capacity, and strategy. So this is the 2 pillars that we would need to create a European Health Data Center and a common European strategy. And then in that paper, I look at the options, I look at the institutional frame, and when you're presenting options to the European Parliament, you should look at all the extremes. So the sort of the do-nothing scenario, we don't change anything, a more aggressive strategy, which is to approve some changes in the proposals of the European Commission, using the same institutional arrangements, create some additional functionalities in data analytics at the European Union level. The second, more aggressive option would be to pursue the idea of a more interesting HERA agency. HERA agency has been launched by the Commission meanwhile, but it is a very weak agency. If you actually read the material about the HERA agency, so in this option 2, I suggest that maybe we could have this data capacity in the European Centre of Disease Control, or under the umbrella of this European Health Data Space legal proposal, or the final option, which is my honestly preferred option, establish a European Digital Health Agency. So in my opinion, health data is so valuable and it is so important to prepare the future of health in Europe in terms of preventive care, in terms of research, that at the institutional level, we should perhaps create an agency only focusing on healthcare data. And of course, in terms of the strategy, this agency would be entitled to develop a health or public health data governance act and build the strategy on top of that legal piece. So basically, we would need 2 legal pieces: one to establish the agency and one to establish the strategy. And why would that be a good idea? And you can go into the document and find in page 57 that there's a long list of functions that this European Health Data Center could do, from data utilization during a crisis, networks of actors, using AI tools in health, advanced telehealth capacity, looking at surveillance, real-time surveillance of citizens regarding AI-based and telematic solutions. Now, of course, one could create a temporary structure for this, or one can create a permanent structure. In my opinion, that is the preferred option. And then why? Because we could do more things, but of course we would need legal provisions for emergency-only digital services. So if we're going to do things like surveillance of patients, and you know how COVID trace apps have been not well accepted by population, right? In most countries, people did not like the idea of having an app on their phone to trace their life regarding the contact tracing apps. So we can use IT to do a lot of things, but perhaps we can only justify legally that we can use IT to do those things in a certain emergency context. And we need to devise legal instruments for that. But if we are to have them, they need to be fast. We cannot wait 3 months to activate an emergency clause in a legal instrument. So a full European strategy on how to collect data for preventing, detecting, and curing diseases would cover these aspects: preparedness, capacity building, technology-based public health functions. Most public health functions are very paper-based, and then foresight and horizon scanning for emergency health threats. And then in this case, very quickly, what I do is I shows all the options and what would need to be done. So if we were to go for the fourth option, this would mean that member states would have more data. We would have more data of the 4 types of data. The European Health Center, the EU Health Data Center, would be the center of this European health data space. And of course, we would have a European Health Data Space Act and a Public Health Data Governance Act as the 2 legal instruments to build this vision. Other options are, of course, to try to use the existing structures. So in this case, the center is one part of the network of all the organisms that use health data. And in the other one, it doesn't exist as such. Basically, what we have is instruments that can use data in a very flexible way, but there's no agency. There's no one doing this. I have to tell you that right now, the way Europe is going is on this one. Okay, so we are now discussing the European Health Data Space legislation with some elements of centrality, with some elements of central control, namely by DG Santé. So basically, the proposal of the Commission, as it reads right now, is the creation of a European health data space, so a legal infrastructure that allows the usage of health data in Europe, but the entities that are going to use this data are different parts of the Commission, orchestrated by DG Santé, and not by a specific agency or a part of an agency. Okay, so I think conclusions of that work were that the EU can prepare for foster more likely hybrid threats, bio and cyber viruses, for example. This is what we call a hybrid threat. Is if we had COVID and WannaCry. I don't know if you remember the WannaCry crisis and the WannaCry virus, which was a cyber virus. Now, if you imagine that you have at the same day or at the same week a WannaCry attack, which in the case of the UK meant that the hospital stopped working normally for 2 or 3 weeks. Now, can you imagine that crisis happening in the first weeks of the crisis of the Corona crisis in Italy? That would have been a super nightmare, right? And this is the type of crisis we need to prepare, in my opinion, for the future. And we are nowhere near the level of preparation. We have legal pieces for cybersecurity in Europe. We have European pieces for bio threats, but they're not mixed. So thank you very much on that, and this is what I had for you. I hope that was inspirational, and that you've enjoyed 1 hour on the European Health Union, how we are, how I see it, and how we could be in my perspective.
Thank you, Professor Martins. It was indeed inspirational, and I think that it really takes a really unique synthesis as yours, as your particular professional and scholarly figure to conceive such a complex canvas. Thank you so much. And I wonder whether there are questions, comments, and Andrea.
Just a clarification. I don't understand what you mean for that data with public health relevance or something like that.
Okay, so Andrea, for example, data with public health relevance is, for example, the movement of people in a city. So in the case of COVID, when the first cities or countries decided for lockdown, there were some public health authorities asking the city council for mobility data, because the mobility data, you don't need to know who is moving, but by knowing that you have a reduction of 40% or 50% or 60%, you can know if your measures are working, right? You can use, for example, the number of phones that are in a street to identify how many people are plugged into the same closed space, sharing their viruses with each other. So mobility data, telecom data are perhaps the two most interesting data sets that can be used, which are not traditional health data, but that they can be useful for health purposes. That's the concept of public health relevant data.
Okay, so and
thank you, I guess.
Also possibly health lifestyle data.
Oh yeah, lifestyle. I mean, the food, for example, the amount of vegetables. I mean, in a city, let's suppose the city is buying less and less vegetables, right? This is important information for promoting a campaign on vegetables and fruit.
Yeah, and this data would not be would not probably fall under, surely they
GDPR.
don't fall under under the sensitive data category.
That's the beauty about some of these things, is that there's a lot of public health in decisions that you don't need personal data, you need population data. And the idea that population data is a sum of personal data is a misconcept. Population data,
I absolutely agree with you. Yeah, it is a totally an utter misconception. Yeah, Jonathan also agree with you. There are.
I would like to say that also data could come from the Earth observation. So firms from Earth observation are using observation from satellites. Also, the European community has done a lot of things, for instance, the Copernicus program. And for instance, they do some like Big Brother. So, for instance, look at raw materials which arrive to some importance to some firms in order to understand shortages which are coming and to predict what this will bring to customers. So customers can understand raw material shortages before they really see it. So perhaps also these data, and this could be easier because the European community did a lot of effort to make it free. This data.
Definitely. So, I mean, what I think is common to what we are discussing now is that you need the concept of a system, right? A system that, and what is its purposes. So if the European level can help national levels with alerts, with a system overview, it works as a sort of a satellite, a health satellite, that is sitting somewhere, using this data to alert people and alert communities and alert professionals to certain trends. And I think that is, I mean, to some extent, that is the purpose of Health at a Glance report. I don't know if you know this report from the OECD that is actually paid by the European Commission. But in a way, it's the decisions you take are so short. And because the report always takes 1 or 2 years to process the data, it's always delayed. You can't make decisions based on last year's report. So this real-time surveillance, real-time data analytics, this is the challenge of the future, and we need to prepare for that. This is like having a monitor for the heart that is giving you the beats of 10 minutes ago. That can't help much, huh? So if you're a doctor in intensive care and all your monitoring systems have data from 10 minutes ago, how could you take care of the patient, right? It can be that without you noticing it. So that's a challenge, and I hope you've enjoyed this moment. It was super interesting, and please make sure we stay in touch. Thank you so much.
Yeah. Thank you.
Thank you very much. Ciao, ciao, Francesca. We talk on email.
Thank you.
Thank you all for
Yes, of course. Thank you. Bye.
Bye.